Next one, outcomes of retroperitoneal versus transperitoneal approach for open abdominal aortic aneurysm repair stratified by aortic cross-clamping site, presented by Dr. Mohammed Hamouda from the University of California, San Diego.
Hello, everyone. Good morning. Thanks for letting us present our work. My name is Mohammed Hamouda. I'm a postdoc research fellow at UC San Diego. There's a mouse. I can use a mouse. Right here. Okay. All right. So we have no disclosures. Abdominal aortic aneurysms occur in more than 1% of patients in the United States over the age of 50. And we have more than 200,000 new cases diagnosed with AAAs every year, more than 15,000 deaths every year if they present with rupture. The first successful AAA repair was by Charles Dubost in France in 1951. However, the conventional AAA repair that we know of today is after the introduction of the usage of Dacron graft by Michael DeBakey in the mid-1950s. In the United States, more than 80% of AAAs are treated with EVAR and not open repair. However, we believe AAA repair is here to stay as it's the most durable option. There are several studies published in the literature. One of them is in the New England Journal of Medicine, and the other one was by our team published in JAMA Open, where we're able to show that there is reduced risk of mortality, rupture, and reintervention up to 6 years with open repair compared to EVAR. So for open AAA repair, there are two main approaches to expose the aorta. The first one is the more common one, the transperitoneal anterior approach. Most vascular surgeons are familiar with it. And the other less common one is the retroperitoneal exposure or the lateral exposure to the abdominal aorta. Advantages of one exposure technique to another. We see that the transperitoneal approach is the one that is more familiar to most vascular surgeons. You can expose the whole abdomen, you can run the whole bowel through this anterior approach, and it's easier to expose the right-sided vessels through this approach compared to the retroperitoneal one. On the other hand, the retroperitoneal approach is easier to expose the suprarenal aorta, and also it's easier to treat complex aneurysms through this approach, such as the suprarenal and juxtarenal aneurysms. It's very valuable in patients who have hostile abdomen because you don't need to enter the peritoneum. And the literature shows that there's fewer GI complications with this approach compared to the transperitoneal approach. So moving on to the location of the cross-clamp of the aorta. Usually, in a patient with an infrarenal AAA, the only thing we need is just an infrarenal clamp. That's the most common clamp site. However, there are certain situations where you need to clamp more proximally above one of the renal arteries or interrenal cross-clamping. Also in clamping above both renal arteries or suprarenal cross-clamping. And sometimes we even need to clamp higher above the celiac artery or supraceliac clamping. We all know that clamping above the renals in the aorta is a very risky move and is associated with postoperative dialysis, MI, and bowel ischemia. However, there are some certain compelling reasons to clamp proximally, such as in patients who have perirenal or juxtarenal aneurysms. Those are aneurysms that are encroach a little bit to the renal arteries, and also in other patients who have extensive thrombosis or calcification of the neck of the aorta, and in patients who need a concomitant renal bypass or a visceral bypass. So in our study, we aim to compare the outcomes of retroperitoneal approach compared to the transperitoneal approach in order to see which exposure technique is better, but at which clamping site. So we used the Society for Vascular Surgery Vascular Quality Initiative dataset, and we queried patients from 2012 to 2024, and we grouped our patients into 4 groups according to the cross-clamp site. So we have the infrarenal group, the interrenal group, suprarenal, and supraceliac, and within each clamp group, we looked at the outcomes of the retroperitoneal approach versus the transperitoneal approach. We included all AAA repairs in the data set, and we excluded those with missing information, those who presented with ruptured aortas, and those who required open conversion after EVAR. Our primary outcomes were postoperative death, MI, and bowel ischemia, while our secondary outcomes were return to the operating room, prolonged length of stay, and prolonged length of stay in the ICU. We used multivariable logistic regression for our analysis, and we identified the most statistically significant covariates and the clinically relevant variables to include in our regression models. Our analyses were adjusted for covariates including age, gender, race, smoking status, family history of aneurysms, size of the aneurysm. We also adjusted for renal ischemia time and renal artery bypass and cold perfusion. Our study had almost 9,000 open AAA repairs included. More than 70% were in the transperitoneal group. When we look at the patients stratified with cross-clamp site, we see that the most common exposure technique is obviously the transperitoneal approach. However, as we go more proximally with the cross-clamp site, we see that more and more retroperitoneal is being utilized until we reach the supraceliac group, where actually most of the patients we treated with RP compared to transperitoneal approach. Those are the baseline characteristics of patients with both exposure techniques. The patients in the retroperitoneal group were slightly older. They're more likely to be female with history of smoking. They had prior history of hypertension, COPD, and renal impairment. And then there was no differences in preoperative medications. When we look at the surgeon case volume, we see that more and more retroperitoneal exposure is being used by the most experienced vascular surgeons who perform the highest number of mean annual case volume of open AAA repairs in the country. And the same thing was also in the high volume centers where retroperitoneal exposure was done more in the centers with the highest volumes of open AAA repairs. Looking at operative details, it's usually faster to perform the procedure if you want to clamp suprarenal or supraceliac if you use the retroperitoneal approach. Also, more than double the numbers of renal bypasses were done through the retroperitoneal approach compared to the transperitoneal approach. And regarding blood loss, there's less blood loss with retroperitoneal only in the supraceliac group. Now looking at each cross-clamp group separately, and when we look at the infrarenal group, if we want to compare the retroperitoneal approach to the transperitoneal approach, there was no difference in in-hospital mortality or 30-day mortality. There was also no difference in MI, return to the operating room, or bowel ischemia. However, the retroperitoneal group had higher risk of postoperative dialysis. On the other hand, if we're clamping a little bit more proximally above one of the renal arteries, we see that there's also no difference in death, MI, or length of stay. However, there is a 60% reduction in bowel ischemia with the retroperitoneal approach compared to the transperitoneal approach. In the suprarenal cross-clamp group, this is where the benefit of the retroperitoneal approach is actually very evident, as there was a reduction in both in-hospital and 30-day mortality with this approach. There was reduced risk of postoperative dialysis, and there was almost half a reduction of the risk of bowel ischemia with this approach. Similarly, in the supraceliac group, there was also better survival with the retroperitoneal approach compared to the transperitoneal approach, both in hospital and at 30 days. So our study is limited by its retrospective nature and possibility of coding errors and human errors. There are also some unmeasured confounders in the data set, such as the variability in technical skills and surgical training. But in conclusion, we can say that the outcomes of the retroperitoneal approach compared to the transperitoneal approach in our study were found to be modified by the location of the cross-clamp. We see a lower risk of dialysis and bowel ischemia in the suprarenal clamp group if you go retroperitoneal. Also, there's better survival with the retroperitoneal approach if you need to clamp suprarenal or supraceliac. However, there is high risk of renal complications with the infrarenal cross-clamp group. So in conclusion, the retroperitoneal approach is superior to the transperitoneal approach if you need to clamp above the renal arteries. Nevertheless, vascular surgeons must be comfortable performing open AAA repair with either approach in order to provide the best results for our patients. Thank you so much.
Thank you. The discussion will be opened by Dr. Ashraf Mansour.
Thank you, Mr. President. I'd like to congratulate Dr. Mullis and his group for providing us more information on open repair of abdominal aortic aneurysm, which in my view is becoming a lost art. It's one of my favorite approaches, which I enjoy teaching our residents and fellows, because sometimes you need that in a pinch, especially when patients have reasons not to have the transperitoneal approach. And I remember one of my mentors saying that if you have an obese patient, it's very difficult to go transperitoneal, but if you go retroperitoneal, everybody's thin. So I have three questions. less than a third of your cases in the Vascular Quality Initiative was done retroperitoneally. Were there regional variations? And specifically, as some of the vascular surgeons in the room know, the Albany group in New York, basically that's their approach in over 90% of our cases, whether elective or ruptured. So I'd be interested to see if the VQI data actually shows that. My second question, and I know in the presentation you said you excluded ruptured aneurysm, but were there symptomatic aneurysms that were done in the retroperitoneal approach, and were the outcomes known in that group of patients? And lastly, I think that the main drawback of the retroperitoneal approach is reaching the right common iliac when you want to do a bifurcated graft. And sometimes a counter incision has to be done in the right lower quadrant to get to the iliac artery. And I was wondering if there were more bifurcated grafts in the transperitoneal group compared to the retroperitoneal group, because that would make sense in that if you have a large right common iliac aneurysm, the surgeon would be more comfortable doing a transperitoneal approach. So thank you very much for this information. I think it's our trainees need to be familiar with this approach. It's a nice approach, and as somebody said, it goes faster and less complications. Thank you very much.
Thank you. Other questions from the audience?
Thank you, Dr. Bukhari from Peoria. Excellent study. My question was there a variation in morbidity or mortality based on university affiliation, large center, small center, geographic location? Thank you.
Thank you. From this side, another question?
Hi, Alex Shepard from Henry Ford in Detroit. It's always nice to see a paper that confirms one's own bias about retroperitoneal versus transperitoneal approach to the aorta. I would bring out one other major advantage of the retroperitoneal approach, and that is the much reduced rate of incisional hernia. We know that from large transperitoneal series, the rate of incisional hernia approaches 30% at 5 years. And I think you'll find with the retroperitoneal approach, the rate of hernia formation is much lower. The only other thing I would say is for those of you vascular surgeons in the crowd, I think you understand that the worst thing you can do is to start out with an infrarenal clamp and then halfway through the case decide that you need to move the clamp farther proximal. Those are the patients that do worse. I don't think this is reflected in the VQI data, but I think it's a teaching point for our younger fellows and trainees. Thank you.
Thank you. Dr. Tofai?
Sherman Tofai from Beverly Hills. Thank you for that comment about hernias. As a hernia surgeon, we all know that AAAs are at higher risk for incisional hernias of any kind than the average patient. I would also say that in addition to the risk of incisional hernia, having these oblique incisions makes you at higher risk for denervation of the abdominal wall, which is a much more difficult problem to handle than incisional hernia. So I'm curious if the VQI captures hernias and or denervation in their outcomes.
One more question.
Sorry to rise again, but in terms of the denervation, that is a very real problem. We have patients sent back to us, I'm sure Dr. Malice sees this too, where the primary care doctor is worried about a hernia, and in fact, it's just denervation. One of the ways to avoid that is to bring the incision straight across between the intercostal muscles as opposed to cutting the muscles. We initially did this procedure and brought it down from the 11th or 10th intercostal space, just halfway between the symphysis pubis and the umbilicus. That would invariably cut a number of intercostal nerves. If you keep that incision more horizontal, bring it over to the midline, that complication can be virtually eliminated. I apologize for rising a second.
Thank you. Any other questions from the audience? If not, Dr. Mahmoud Malas will be closing from University of California, San Diego.
Thank you so much for giving us the opportunity to present this work. I just want hopefully there are a lot of PDs here, but to take note of Mo, who did phenomenal job with this, will be applying for surgery soon. And he's also the first author on the next paper that I'm going to present. So phenomenal job, Mo. So as far as this is very important, I think when I started as a fellow of Frank Vieth, at that time, 10% of all aneurysm repair were done endovascularly, and now it's the opposite. So over the last 3 decades, almost 2 decades, we now doing almost 80 to 90% of our repair endovascularly. And the major problem with this is that we probably treating a lot of patients that should not be treated with endovascular repair because they don't have good anatomy for it. And then we are now dealing with these patients that we treated for the wrong indication 10 to 20 years. So now more than half my practice of open repair is taking failed endovascular graft, which make the procedure 10 times harder with much worse complications. So I think the key point is to remember that we're surgeons and we need to be very good surgeon before we're endovascular surgeon and not lose this art, as Ash has mentioned. Um, so as far as the repair initially, since as Mo showed, since the Bakey did the first open repair in 1954 with the Acrine graft, about 3 years after the French surgeon Dubois, who used a homograft, essentially all open AAA were done first with the transperitoneal approach. It wasn't until the 1980 that the retroperitoneal approach was introduced. And then we have a very rich literature with so many different papers that compare the two, and it's all over the place. We know for sure that retroperitoneal approach have less pain, require less narcotic. The patient breathe faster, they get up and move. We don't violate the bowel, we don't open the peritoneum, so we have less ileus, the patient eat faster. Both these things lead to the patient leaving faster. But you will see literature, as everything we do, literature supporting whatever you like. So the people who do transperitoneal, there are a lot of literature that says better, and the people who do retroperitoneal, there's a lot of literature that suppose that it is better. So the concept with this study is, why don't we look at the clamp site as an effect modifier, which nobody have done, and do this study. This is the largest study to date in the literature with, as you saw, 8,842 patients. Why don't we see if the clamp site is really why there's so much variation? And this is exactly what we found. We found that if you do a transperitoneal and clamp infrarenally, you might even have more complication with the retroperitoneal. There's no benefit of the retroperitoneal approach. And once you start going higher, so intraperitoneal, suprarenal, and intrarenal clamping was associated with dramatic reduction in bowel ischemia. And supraceliac was associated with less mortality as you have less stress on the heart as you get closer to the heart. And of course, suprarenal clamping was associated with less renal complication, not surprising at all. But this was only if you do in the transperitoneal compare to the retroperitoneal compared to the transperitoneal. So this is what this paper showed, different than the literature, that the advantage of that approach is very magnified as you go higher with your clamp. As far as the question, Ash, thank you for this important question. And I think one of the your first question was on regional variation, and one of the people that stood up, sorry, I didn't get the name, also talked about regional variation. So VQI is very protective to the surgeon and to the site. They don't want one site to have worse outcome and everybody see it. So we have essentially blinding of the center ID. We do get a random number that this is a center, but we have no idea where is that center. And I think there was a question later also about regional variation. So we can tell that from the data. We can sometime request from VQI a separate protocol to get this, and they have to go to every center and get their approval if they allow us to see. So we cannot answer if there is a regional variation or center variation, but we know that you're absolutely right. Some centers do more retroperitoneal, and Mo showed that the larger the center and the more experienced the surgeon, the more complications. So I think, we try to accommodate that by introducing a cluster by center within the regression model, so we can account for these regional variation. You're right, there is no rupture. That was your second question, but you added the symptomatic status. Yes, we included that. We adjusted for that. So that was also included in the model. And the third question about the right iliac, that's the hard part with retroperitoneal. Sometimes it pops right into your face, and sometimes it's super, super deep, and you have to do an initial incision. So I think, unfortunately, VQI does not give you the configuration of tube graft versus bifurcated, so we cannot do that as well. And I think there was a question by Dr. Shepard, a couple of questions about incisional hernia, and Dr. Trofa also asked about hernia. We don't have that in VQI, but that's super important because, that's one of the major complications of open rare long term. And that's really where the re-intervention rate maybe can be equivalent between open and endo if you include the incisional hernia, but we don't have that in VQI. So thank you so much.
Thank you.